Good evening and welcome to the 5th edition of the ERS Vision Live panel discussion featured exclusively on the ERS Respiratory channel. Today's discussion will focus on new therapies and treatment strategies in mild asthma. The talk will be broken down into 3 parts in which the panel and speakers will explore the potential improved patient outcomes of new therapeutic options from the patient's perspective, the recent updates to GINA recommendations in support of these new therapeutic strategies, and finally, the challenges that we face in implementing these new recommendations. We are delighted to welcome today's panel, led by Guy Bruxelles, past ERS Science Council Chair, and Professor Arzu Yorgancholu, current ERS Advocacy Chair. Guy Bruxelles is Professor of Medicine and soon to be head of the Department of Respiratory Medicine at Ghent University Hospital in Belgium. He was the ERS Guidelines Director from 2012 to 2016, and ERS Science Council Chair from 2016 to 2019. He is a member of the GINA Science Committee and Board. Arzu Yorgancholu is a Professor of Respiratory Medicine at the Celal Bayar University in Turkey. Her research interests focus on obstructive lung diseases, asthma and COPD. She is also a member of the GINA Board. Good evening, Professor Yorgancholu and Professor Bruxelles.
Good evening.
Good evening.
And
thank you
for organizing. Good evening, and thank you for organizing this very important session on ERS Vision.
It's absolutely lovely to have you here with us today. Joining us to help understand the experiences of mild asthma patients is Michaela Odermeer. Michaela has spent many years working for the non-profit local organization Asthma and Allergy Association in Örnsköldsvik, Sweden. For the last 20 years, she has been giving lectures in schools, hospitals and restaurants to different authorities and parents on living with allergy and asthma for children and families in the northern part of Sweden. Welcome, Michaela.
Good evening, and thank you.
Thank you so much for joining us. So, to move on to the next section, Professor Bruxelles, for the past 10 years, have there been significant new therapies produced for the treatment of mild asthma?
Absolutely, yes. So, first of all, there are new drugs in clinical development, and we are eagerly awaiting the results of the phase 3 studies of several drugs, including new combination inhalers. But that's the classical drug-centered approach. And what we have seen in the past 5 years is the development of new treatment strategies for the treatment of adolescents and adults with mild asthma, using well-established effective drugs, but in a novel manner. And we will discuss this especially on the combination inhalers of inhaled corticosteroids with formoterol, a fast-acting and long-acting bronchodilator used as needed. And this new evidence is based on 4 large randomized controlled trials, really landmark studies, but using a patient-centered approach. And so patient-centered research is of course, a very important addition to the drug-centered studies. And we are very, very glad to have Michaela in our panel discussion, because she, as a patient, herself will give us the patient perspective, which is critical. Michaela is representing also the ELF, the European Lung Foundation, which is overarching many patient organizations in Europe, including asthma patient organizations. And so, Michaela, so welcome, and thank you for joining us. And so, of course, you now have asthma already for many years, but let's go back in time to the first years of the disease. Could you tell us, please, what were the complaints? Which complaints did you have? Which symptoms did you experience? How did you feel? So could you tell us this, please?
Yes, well, it always started with me having cough, always, especially when the flu season came. I also got sick immediately with a cold or with the flu. And also when I was doing sports, I felt breathless. And also when I was running to a train or something like that. And I always ended up at the primary care, at their ER. And actually it took quite some years before I got my diagnosis. And I remember once I was there and he was listening at my lungs, and he looked at me and he say, "Are you sure you don't have asthma?" And I said, "Well, you tell me, you're the doctor." And he was a very good one. So I did the spirometry and everything. And then, so he helped me a lot. But again, I think it took 4 years till I got my diagnosis.
So thank you for sharing this with us. It's already a first important message that there is sometimes a delay in diagnosis, and so we should do better. But once the diagnosis of asthma, mild asthma, was made, how were you treated, Mikaela? And which challenges did you experience in adhering to this treatment?
Well, first I got the reliever medication, and it worked very well. But one thing that I then discovered is when I was using it, I got quite shaky. So when you're doing their makeup and things like that, it was tricky. My children also have asthma, and they also experienced this when they were going to have a test in school and they were going to write something. They thought it was very tricky. And I must admit that the adherence from my side wasn't the best. As long as I had this cold or the cough, I was taking medication. I had 2 inhalers. I was then prescribed corticosteroids. But as soon as I felt a little better, I stopped taking it. And it came again. So every year it was the same. I went to the primary care and had to inhale. But the only positive thing I can say now when it comes to COVID is that my adherence has improved so much, because since last spring I've been using my medication just as the ordination, and I haven't had the cold. I didn't have any exacerbations. I feel really good. So now I do understand the need of taking the medication daily. And when it came to my children, of course, with them, I took care of them totally spot on. But to myself, the adherence wasn't good. I admit it.
So again, a very interesting and important message. And could you tell us, so when you started then in the inhaled corticosteroids, for how many weeks or months did you use it regularly, or?
It was weeks. It was not
weeks.
months.
Weeks. Yeah. No. So yeah. So that that's real life. So and I think that you represent many patients who behave similarly. So we have excellent drugs to treat asthma, but they only work when the patient uses the drug, the medication. So for you as a patient, what would be the ideal treatment regimen? How would this look like?
Well, easy to use, and now I have a combined inhaler, and so it makes life more easier. And I think also that in these days now we have digital health and apps, and I use the app for reminders. You need to have this, exactly when you need to take your medication, this routine. And if we look at the younger generation, they have their mobile phones in front of them. So this is a great way of communicating with them. And I also see the benefits, because in my app that I use, I have the pollen count, I have how the air quality is. So, and also I can follow my asthma. And it's like a little reward when I see, oh, your asthma is under control. Again, maybe this will not work for everyone, but it's a very good help.
So this is a very important hint. So I was wondering, so you admit that you were non-adherent. There are different forms of non-adherence. And so you have patients who are non-adherent intentionally, and they don't want to take or use the drug because they have concerns about the side effects, or they don't believe that they will benefit from the treatment. And there's of course then the non-intentional non-adherence, so patients who forget to use the inhaler because they are too busy, they have so many other things to do. So which type of non-adherence was yours?
Mine was as soon as I felt a little better, then I thought, okay, I don't need it. But I think here now seeing when I've been using it since the COVID started, I can really see the benefit of it and understand why. So I think here is communication also with the GP. The thing is also I only met my GP when I was diagnosed. Since then I haven't seen him. I have an excellent asthma nurse, but so far I don't have an action plan or no follow-ups. And I think this is also important to the adherence to have these checkups regularly. But for me, it was just, I think, a bit lazy. And when I felt, and with asthma also, you get used to the way you breathe.
Yeah, now, Michaela, you're absolutely right. So, adherence needs a combination of course, a good physician-patient communication and shared decision-making and interaction, but also to overcome several barriers to the use of drugs. And were there additional barriers for you to use the treatment?
Well, from the beginning, first I had just the medication on demand. And now when I have it regularly every day, I really needed to know why is my asthma getting worse. So that is one barrier, that you get anxious, what is happening. Again, the communication. For other patients, it could also be economic. Well, when you used to take the medication on demand, that was less cost than if you take it now on a daily basis. So for me, the barriers was, I really think the barriers was more that I really needed to understand how good this is, because like I said, I haven't had any exacerbation. I didn't have to go to the primary care at any time for the last 2 years. And this is amazing. And now I will not stop taking my medication.
Perfect. I want now to invite Arzu to join the discussion and the Q&A session. So please, Arzu, go on with this important topic and the patient's perspective.
Thank you. And thank you, Michaela, for expressing your lifelong experience with us, which is very teachable to many patients. We have one question from the audience asking you, do you think that you will take your asthma medication if it came in a pill instead of an inhaler? What do you think about this?
In my case, I would say yes, as easy as possible. And I don't have any problems with swelling medication. So, yeah.
Okay. And I would like to ask a question myself, and I'm hoping to have your sincere answer for this. How do you define the role of the patient in the management of asthma? How important it is, do you think, that the patient's preferences could have an impact on the treatment and on the management of asthma?
Well, it has a huge impact, because if we speak the same language, healthcare professional or GPs together with patient, if you have clear guidance, so we understand why we're taking this, why we're doing this, then I think the adherence will be much, much better. And also, one thing that we haven't been talking about is the technique of the inhalers. I mean, I have had it for a long time. I think I have had 3 different inhalers during the time, and they are all different. And this is very important to be sure that the patient take the medication, because if we take it wrong, they will say, this is worthless, I don't use it. So there are many factors here. So talking to the patient, then you see their barriers or their questions. So I think together, teamwork, that will be the best practice for everyone.
And you also mentioned during your talk that you get used to the level of breathing yourself and you adjust your life accordingly. But we as physicians strongly push our patients to raise the bar and to have or to target a complete control. What do you think about this?
Yeah, but that's right. But I think also here you may need help to so you know exactly how you will be able to do these sports. And if you make that message, yeah, if you take your medication, you can go skiing or play football or whatever. Because a goal for a patient is they will follow it. If I, for example, I love skiing, and if they will say, if you take a medication, like we say, then you will have no problems with skiing, I think I would have done it a bit better. That is not their fault, but I think you have to put it on the patient level. What is the goal? What do you want to do?
Yeah, perfect. And you also mentioned the importance of digital health and the applications in smartphones. That is very helpful, right?
Yes, I think it's because then you got the reminder when to take the medication. You can put an alarm, of course. But if I look at the younger generation, like I said, I have 3 children with asthma. They have their smartphones in front of their nose always. So communicating there is a great way of helping them also, as long as they have this mama app, me telling you have to take the medication. But once they have to grow up.
Okay, we have some more questions, and we have 5 minutes. Guy, can I ask the other questions?
Yes, it's a question about, for example, if the physician is checking whether you received the prescribed inhalers by the pharmacist, and so looking at prescription refills. Did you feel that your privacy was not respected, or you don't have any problems with this? Because you mentioned correctly the digital health and the opportunities for e-health and long-term and checking the adherence of patients. So you don't have any issues with privacy?
Yes, I do. But for example, the one I use, I know, because you have to think of GDPR. I think the ideal is when a patient and the hospital or the primary care use the same, so I can share, but I own the data, and I can share it with my GP, so he can follow if I have troubles. So I don't trust any apps. It must be an app or a digital health that I know of. That I can rely on.
And maybe, Michaela, as a last question from the audience, there are once daily inhaler medications available. Are your barriers to adherence more related to the dosing schedule, once daily, twice daily, or 3 times a day, or to the device itself, the different inhaler types?
No, I take my medication in the morning to breakfast. I have to have this routine because then, so there is no problem with but if I'm feeling ill or having a cough, then I will take it in the evening also. But there is no problem with that. But I need to have that routine. But I have, again, after COVID, now I have a great adherence before. And I see the benefit.
You are absolutely. Yeah, absolutely. You are absolutely right, Michaela, that inhaled corticosteroids, they also are preventive in patients with asthma to reduce the risk of COVID-19. So, of course, the key prevention is vaccination, absolutely. But inhaled corticosteroids are totally safe in patients with asthma, and even they can reduce the receptor where the coronavirus binds to in the airways. So it's interesting to highlight this, because it will also improve the adherence to the treatment. So Arzu, maybe as to conclude this first part.
Yes, thanks very much, and we would like to hand over to Mev now. Mev.
Thank you so much, Arzu. And now I would like to introduce our 2 additional speakers in support of the next 2 sections of our discussion today: an update on the GINA strategy for mild asthma and the challenges presented by the implementation of these recommendations, Professor Dr. Helen Redl and Professor Dr. Celeste Borsberg. Helen Redl is a research leader at the Woolcock Institute of Medical Research and professor at the University of Sydney in Australia. Her research focuses on improving treatment options and understanding mechanisms of asthma and COPD, and the patient perspective in mild and severe asthma. She is chair of the GINA Science Committee. Celeste Bosbjerg is a professor of severe asthma in the Department of Respiratory Medicine at Bispebjerg Hospital, Copenhagen, where she heads the Severe Asthma Clinic and chairs the Respiratory Research Unit. Her research revolves around solving key clinical issues in difficult asthma, understanding disease mechanisms, and personalizing asthma management. Welcome, Professor Helen Redel and Professor Celeste Bosbjerg.
Hi, thank you.
Thank you.
To the second section of our discussion, Professor Brussel. Although there are potential new therapies and combination therapies in development for the treatment of mild asthma, it is maybe much more significant that there have been key changes in recommendation for patient management therapy. Could you summarize these exciting new developments for us?
Absolutely, Maeve. So in the past, and actually in the past 50 years, short-acting beta-2 agonists, so short-acting bronchodilators, have been used in patients with mild asthma, including GINA step 1 till 2018. But thanks to then new clinical evidence, there has been a major change in the GINA recommendations since 2019. Stating that SABA as monotherapy, so SABA as needed but only as the only treatment, is no longer recommended in patients with asthma. And instead, an ICS-containing control treatment is now recommended by GINA in patients with mild asthma to reduce the risk of exacerbations and to control the symptoms. And there are two possibilities for this ICS-containing control treatment, either a maintenance treatment with inhaled corticosteroids, but we heard already from Michaela the challenges of this, or a combination of an inhaled corticosteroids with formoterol as needed in the GINA steps 1 and 2. And so it's a pleasure to welcome indeed Helen Redel as the chair of the scientific committee of GINA, and Celeste Bosbjerg as a respiratory physician in Copenhagen to give their insights and updates on the GINA recommendations. And it's my pleasure to hand over now to Arzu to lead the discussion. Please, Arzu, the floor is yours.
Yes, thank you, Gay. It's my pleasure to welcome these very incredible scientists here. And now I believe that we are all sure that ICS-containing controller treatment is needed to reduce the risk of serious exacerbations, and even in patients in mild asthma, which is the subject of our session tonight. In 2021, GINA treatment figure has two tracks. The first track is the preferred track, having low-dose ICS formoterol as the reliever across all treatment steps. And I am happy to say that this strategy was based on clinical trials in 23,000 patients for steps 3 and 4. And also, that is the MART therapy, and in about 10,000 patients in step 2. So in the light of these huge data, I would like to ask Helen. We know that GINA has made a fundamental change for safety, and GINA no longer recommends SABA-only treatment for step 1 in adults and adolescents. And Helen, is there's enough evidence to recommend these changes to step 1. Why did GINA extend as needed ICS formoterol to step 1 in 2021?
Yes, thanks, Arzu. So as you said, we have strong evidence about step 2 But step 1 is for patients with symptoms less than twice a month. That's a very challenging group to study. And so there it was more from a strategic perspective and a population level perspective. So firstly, that such patients can still have severe or fatal asthma exacerbations. For example, with viral infections, as Michaela was describing, that was when her asthma was worse, when she first started. Using an occasional course of oral corticosteroids might seem innocent enough, but there's increasing evidence for long-term serious adverse effects with even a course every couple of years. But more importantly, from a strategic perspective, if you start treatment with SABA alone, what that's doing is training the patient to regard that as their main asthma treatment. And so forevermore, it's very hard to overcome that instinct to go back to SABA-only treatment. The final reason, I think, is that there's no mechanistic reason that symptoms less than or more than twice a month should have any different underlying mechanism. And so the somewhat indirect nature of the evidence from step 2 was considered to contribute to that rationale. So it was multiple factors, but more than just do we have specific evidence in patients with symptoms less than twice a month.
Yeah. Thank you. Thank you. Thank you for this clarification, because we have been received many questions about the evidence in step 1. So thank you for this. And as GINA mentioned, the preferred treatment is the first track in 2021, but we have a second alternative track, so which includes SABA as reliever, not ICS formoterol from step 1 and step 5. So which patients should we consider for this track? Because we know that the preferred track, as you mentioned, is with the reliever ICS formoterol, but will there be any patients to recommend this second track?
Yes, absolutely.
And how can
the first
those patients?
So absolutely, because the first issue is that in many countries there isn't access to quality controlled ICS formoterol medications. So even if it is available, that it's not suitable necessarily for everyone. And we wouldn't suggest that if a patient has stable asthma, no exacerbations on their current treatment with a SABA reliever, there's no reason why they should be switched. However, before we recommend treatment with that sort of combination of a maintenance treatment and a SABA inhaler, it's really important to think about whether the patient is going to be regularly adherent. So Michaela gave a perfect description of what is extremely common in the community, that the preventer is taken for a few days or weeks around a flare-up, but then the patient drops back to SABA alone. So we need to think about likely adherence when choosing a treatment option, as well as the relative benefit of the two treatment options. So certainly this is not intended as a one-size-fits-all, and patient preference is the other thing that must be taken into account.
And switching between the tracks is always possible, as you said.
That's right, yes. So you can step treatment up or down within a track, or you can switch between tracks according to the patient's need and their clinical status, and also medicine availability.
Okay. We are talking tonight the mild asthma, and we know that compliance is a big issue, especially in mild asthmatics who have very few symptoms. So what do you think about compliance in mild asthma, and comparing our recommendations, GINA recommendations, with this compliance level?
Yeah, look, compliance or adherence is a problem. It's an almost universal problem. If you think about going to the dentist, do you clean your teeth more often before you go to see the dentist? I think most of us do. In mild asthma, the symptoms intrude infrequently, and it's perhaps only when the patient has symptoms that they think of remembering to take their inhaler. So it's a particular problem with the inhaled corticosteroids alone, where there is no bronchodilator component to the inhaler. So if the patient takes their inhaler when they have symptoms, they don't feel any benefit at the time. And so there's not that reinforcement of this is something that's good for me to take. So overall, I think that adherence is easier for patients if they do feel some benefit, if they have symptoms when they take it. But the strategies that we propose need to take into account that we're all human and that adherence is unlikely to be perfect in most patients. So this is not sort of giving in to poor adherence, but it's devising a strategy that will allow for human behaviour and still protect patients from severe exacerbations.
Thank you. We have 5 or 6 minutes for discussion. I would like to invite Guy also. We have a couple of questions. Guy?
Yeah, absolutely. So thank you. There's a lot of interest, and Helen, I will start with the most difficult question. Is there a good definition of mild asthma?
The short answer is no, there isn't a good definition. Yeah, so out in the community, among patients, the word mild is usually referred to the fact that either their symptoms aren't frequent or they're not severe, or that they're quickly relieved by taking a reliever inhaler. That's the most common meaning given to the term mild among patients. And that's actually the most common meaning given to that term among physicians. Now, we currently have a definition of mild asthma in guidelines, but it's not very functional or feasible for clinical practice because it's a retrospective label, just as the label for severe asthma is a retrospective label once you see how much treatment it takes to control a patient's asthma. So this is a topic for intense discussion amongst the GINA Science Committee this year, and it's also a topic for an ATS workshop that is ongoing this year. And so I think we need to watch this space to see what considered discussion about why we need a definition of mild asthma, what do we want the definition to do, and how we communicate about it to patients and doctors.
Thank you for this excellent answer, Helen. And I think you will agree that it's very important to highlight that mild asthma does not mean low risk. And so these are two different concepts which should be conceived separately. Thinking about the very interesting medical history of Michaela, her trajectory, there's a question whether it's more difficult to objectively diagnose mild asthma.
Yes, I think that when symptoms are relatively infrequent, it can be harder to make the diagnosis of asthma. It's key to have lung function testing, but the yield from just doing a single lung function test is poor in patients with mild asthma. So one of the suggestions we make is that to confirm the diagnosis of asthma, it's a good idea to do the lung function testing when the patient does actually have symptoms, and then you can see whether they do or don't have a substantial bronchodilator response. So that's one way of sort of optimizing the diagnostic process, but then also considering the other options available in terms of referral to a specialist. It's so important to try to get the diagnosis confirmed before treatment is started, because once treatment is started, the characteristics of asthma become less, so that well-controlled asthma looks like no asthma. So we do reinforce the importance of trying to confirm that diagnosis as soon as the patient first presents.
There's another delicate question. It's the fact that in several countries, there's no license for isotretinoin in mild asthma. And the question is, should we wait for a license before we recommend this treatment?
I think physicians need to make their own decision about that based on their national guidelines and the regulatory requirements within their country or region. There's always a situation where a physician may make a decision about an individual patient on the basis of the best evidence and the best interests of the patient. But they do need to be able to defend that position if necessary for the patient's best interests. I think there are barriers to on-label prescribing of many conditions. It's particularly a problem for children, where many medications that are needed for pediatric management of conditions are off-label in many countries. So this is not unusual, but I think that you need to think about the option of using it in terms of what is best for this patient, but also think of the other alternative for which there is less evidence, much less evidence, of using inhaled corticosteroid whenever the patient takes their SABA. So that's another option that can be done in countries where ICS formoterol is not available for as-needed use.
I totally agree, and we had similar discussions regarding then in the more severe spectrum of asthma the use of azithromycin, which is recommended by GINA as an add-on treatment in patients with more severe asthma with repetitive exacerbations despite ICS-LABA treatment, and there's no indication at all globally for azithromycin, but it's used because it's efficacious and we know the safety, so it's possible. Arzu, do you have other questions to ask to Helen?
We have lots of questions. But we don't have time. I will choose a question. If patient with mild asthma who does not have any exacerbations for years and takes only ICS, should we stop giving it to the patient for some time, or should we go to another track?
So the evidence from clinical trials is that if a patient stops taking inhaled corticosteroid, it does increase the risk of having severe exacerbations. So for quite some years, GINA has not recommended stopping inhaled corticosteroid, but in fact, patients usually make that decision for themselves and stop taking it. So it is fairly unusual to have that scenario you describe. So I think the as-needed ICS formoterol option is a very good step-down option to reduce the frequency with which patients need to take medication and also the cost to them. And it's in the studies that have been done, it was an effective step-down option, much better than going to SABA alone.
Yeah, thank you. Thank you, Helen. Yi, I think it's time to move to section 3 and hand over to Mayor.
Yeah, absolutely. But I totally agree with Helen that it's a very convenient step-down option in patients who are frequently asking for this. And do I still need to use on a daily basis my controller? So developing guidelines is already challenging, but implementing the clinical guidelines in clinical practice is even more challenging. And so therefore I'm really glad to have Celeste, Professor Borsberg here to deal with this important topic. And so we just discussed with the patient, Michaela, the problem of adherence with maintenance inhaled corticosteroids. It's a problem across all levels of asthma severity, but especially in mild asthma. So which strategies do you apply in your clinical practice to treat patients who are struggling with adherence? Celeste.
Thank you very much, Guy. Well, as has been said, poor adherence is common, and as you also brought up, the reasons behind non-adherence are very diverse. So it's a simple message, but of course, try to identify the cause of poor adherence. There's a difference between not being able to afford your medication and forgetting it. So that's obviously the first step. I guess then in which patients would you go for a PRN approach? And I think it's a very good question. I think a lot of us have used the SMART principle, the regular use of ICS, LABA plus PRN in patients who were a little bit erratic or chaotic in their lifestyle and maybe a little bit forgetful. And that's possibly the patient where you could use this approach when you have done your best with asthma education, etc. I, at the same time, think that Michaela's story also tells us that if your patient has a clear understanding of why they need to take their medication, they will take it, and all patients should have the opportunity to experience how it is to become well controlled. So it's important to keep a focus on educating your patients to understanding what is good asthma control, what is good asthma management. And I think that is highly important when we want to use an as-needed approach. With giving more responsibility to the patient. So we need to sort of be there to ensure they know what they need to know about their disease.
And indeed, also asking the patient for what are his or her goals. For example, skiing for Michaela. And then if you enforce the message that with a proper treatment, this will be possible, that will indeed improve the adherence. So to my opinion, we can also, we as a respiratory community, we can learn from the ENT specialists, because we all know that nasal vasoconstrictors, they can be used for a short while for the treatment of rhinitis, rhinosinusitis, but the ENT specialists already for many years or even decades, they don't use these drugs longer than 5 or 7 days. So with respect to the SABA, which is of course already 50 years on the market for the treatment as a bronchodilator in asthma, we still see even today patients who are overusing SABA. What do you do in your clinical practice if you are confronted with a patient with asthma who is overusing SABA?
I think my first thought is that I have a problem. I always check the prescriptions that they've picked up, and if I see a lot of SABA, I think, oh no, that's not good. A heavy SABA overuser is difficult to help. They seem to get very stuck on this medication, and I guess my best approach would be to avoid ending up in that situation. So I guess it's a question of trying to identify who could become a SABA overuser. I don't think it's everyone. It seems to be a specific type of personality or the way that they understand or don't understand their disease. So, and I even see this a lot in the patients that I manage with severe asthma. They can also be heavy SABA overusers. So I guess prevention in this case is the best cure, I would say.
Yeah, absolutely. And so one possibility of preventing it's of course not starting it in patients with mild asthma in GINA step 1. And that's a major contrast with the old recommendations before the major change in GINA in 2019. But of course, respiratory medicine and also the treatment and management of asthma is evolving over time, so it's work in progress, and there are possible research gaps still to fill in mild asthma in general, and then also with respect to as needed ICS formoterol as a treatment in patients with mild asthma. So what are the research gaps still needing to be addressed, and how should we address these gaps?
Well, I think that there are a few gaps, and this is of course a very exciting development in new strategies that try to aim more for what the patients need. I think one thing that is clearly a gap, and that probably a lot of us struggle a little bit with, is which patients to use these specific approaches in, as we've discussed briefly. And I think, to my mind, is it that very well-educated, knowledgeable patient who understands their asthma and who can take on responsibility for a PRN approach? And this, now we're not talking about step 1, but step 2 mild asthma. So you would have from time to time poorly controlled asthma, or is it that patients with poor adherence, erratic behavior, can we fix poor adherence? As Helen said, probably this is not the fix for it. So I think we need, and this is probably the opportune moment to have larger real life studies to understand which patient profiles benefit. And then secondly, I think the option that GINA puts forward to choose between either a regular dose of ICS or a PRN approach of ICS LABA is something where I think it will be important to have more longitudinal evidence to understand whether in some patient groups this as per needed approach could have a risk of an accelerated loss of lung function due to a relative undertreatment of airway inflammation. And obviously we don't have that long-term data yet, and I think specifically we need studies that look into measures of airway inflammation and, importantly, airway hyperresponsiveness. I think specifically because I work with severe asthma, I would be keen to understand whether those patients who develop severe asthma, it seems like they are often the patients who were undertreated previously and did not respond to their symptoms. So with those patients who are poor perceivers, would they be at increased risk of progressing in their asthma severity? So those are just the three, I think, most important things that I would like to see more evidence about.
Yeah, of course, since this is a novel strategy, the as needed ICS formoterol in mild asthma, we only have 1 year clinical trial data yet, but of course, longer term follow-up is very welcome. In the novel START study, there are data on FeNO as a measure of eosinophilic airway inflammation, and this was reassuring. So it was a similar suppression of the FeNO levels as in the maintenance ICS treatment, but indeed data on bronchial hyperresponsiveness on the long term are still lacking. So there are many opportunities for further investigating the benefits of the as needed ICS formoterol approach in mild asthma. And we invite all colleagues worldwide to contribute to this, and not only specialists but also primary care physicians. Because again, thanks to Michaela, we heard that she was mainly seen and treated in primary care as most patients with mild asthma. So it's very important that for future clinical research that GPs are heavily involved and also participate in this. So Arzu, can you join us in the discussion on this topic, on the implementation of the new GINA guidelines in mild asthma?
Of course, I will be happy to in 2 or 3 minutes we have. I do believe that, having said that, great recommendations depending on the very strong evidence. But if we cannot implement them, there will be nothing. And implementation in low and middle income countries is so important. And I would like to ask Celeste what she thinks about low and middle income countries for implementation.
So I think in low-income countries, it possibly is an issue, the cost of the medication, depending on local legislation. I certainly think it matters a lot for patients who don't have a lot of money for their treatment. And of course, I guess you're also talking about the countries where you don't have availability of the combination products. And then I think there we have, of course, the strategy to recommend that the patient always takes an ICS inhalation with their SABA. It's sort of a pragmatic approach. I think you need to educate your patients well to understand why it's important to take 2 puffs. But again, I think that's where the good asthma education is something that we mustn't forget how far it can bring us.
Thank you. Thank you. Yes.
Indeed, it's important to highlight that the World Health Organization list of essential medicines encompasses the ICS formoterol. So that's already an important first step, but it should be available and affordable in all countries, including low and middle income countries. That would be a huge step forward. Because unfortunately, and so there are, in 2016, for example, there were 400,000 asthma deaths worldwide, and most of these asthma deaths occur in low and middle income countries, including in patients with so-called mild asthma. But of course, these patients can also be at risk of severe attacks, so it's important to deal with this challenge. Another question from the audience is what do you think about using ICS formoterol once daily plus PRN in polyadherent patients? Of course, this is the MART approach, but so Celeste?
Well, I think that is one good way to go. I mean, I certainly agree with the concept that sometimes we just need to do our best to make things work in the individual patient. And so even though usually you would say it has to be twice daily, if once daily plus PRN works for the patient, that's fine. As long as you follow up and as long as the patient knows what good asthma control is and what it means to be able to do the things you want to do, I think it's okay to go beyond the standard dosages, as long as it's not instead of, as Michaela was telling us, she's never had a written asthma plan, she doesn't see a doctor. So I think it really depends on whether you are in good hands, whether you have a good asthma education or not.
But the beauty of this approach is the flexibility. And so, for example, if you have a patient with mild asthma during the year, but then more severe complaints during, for example, the birch pollen season in the northern hemisphere, that's in Belgium, it's in April. So then during that month, you can use at least once daily the ICS formoterol as maintenance, plus then as needed on top of it. And outside the pollen season, for that particular patient, you could use it only the as needed ICS formoterol. That's what I do in my personal practice, but depending on the individual patient, so tailor-made.
Yeah, I think it requires your patient to have both a good understanding and a normal lung function, no exacerbations and all that. So it really depends on the overall to your patient, doesn't it?
Yeah, you're absolutely right. It's important to highlight that there should be no risk factors for severe asthma attacks. So therefore, a normal lung function and no history of severe exacerbations. So I think we need to close this third part. Thank you very well, Celeste and Helen, and so it's time now for to wrap up and to give a summary of this ERS Vision, if you allow, Arzu. So it was really a very important and excellent discussion, and so to give take-home messages, Arzu, could you provide yours to the audience? What are your key points to take home?
Of course. My understanding today is that GINA is a SABA-only treatment-free report with a great rationale behind, I may say. And patient compliance, we agree that is poor in mild asthma. And if you treat a patient with a SABA as a reliever, and if she or he is not adherent to ICS therapy, he or she will face the adverse outcomes as exacerbations. So we know the higher use of SABA is associated with these unwanted outcomes. So, and if there is, and we don't have any efficacy or safety data for SABA-only treatments. So as long as we have as an alternative with a 10,000 patient data, a more effective and safe alternative, we should deal with this and see the results. And I wonder if we can ask Michaela what impact this may have on our patients' quality of life now. Thank you.
Well, I think it's like Celeste said first, patient education, make the patient understand, have clear guidance, patient-friendly information. So if they understand this, then, and also that the disease will not stop you for doing things you really want to do. And I have always said to my children, yes, you have a disease, but you are not a disease. So I think that is, and communication with patients and healthcare and GPs, professionals, that is the most important. So we understand, why do we take this treatment? Because you all want to help us and we are grateful. We just need to understand why.
Yeah, absolutely, Michaela. So communication, first of all, of the diagnosis, and then of the benefits of the treatment, the long-term and also the short-term impact of the treatment, and the reasons why it's important to use it. So then coming to Helen and Celeste, what are your take-home messages for today's discussion? So Helen, please.
Yes, I think what we've been talking about is thinking about mild asthma from the patient's perspective. So a treatment that will relieve their symptoms, that won't be burdensome to them, and that will allow them to achieve their goals. But also to think about it from the population perspective. So partly reducing the risk of these severe attacks that are so damaging to patients and to the health system, but also looking for confirmation that the evidence we've seen in the studies to date is very reassuring about there not being deterioration over 12 months. So I think that's reassuring and supports the fact that it was time to make a change to non-evidence-based treatment for the last 50 years and to implement something that we need to move towards better asthma outcomes for everyone.
Absolutely. So, but of course, it's also a change in habits. So habits of patients, habits by primary care physicians, habits by respiratory physicians. So, and changing a bad habit can be difficult. So, but of course, there are also research gaps that we need to close. So, Celeste, can you highlight your take-home messages for future research and future GINA updates?
I think, as I said, understanding more about what is the best patient to choose these strategies in would be a wonderful further development with patients well-educated such as and well-informed such as Michaela is talking about. I think we can drive good asthma management forward. So the more patient-centered, more qualitative approach would be fantastic to build on to the advantages of this new strategy from GINA. And finally, I think just as a closing remark, I think it would be very good if local societies had their own discussion of how to implement these new strategies in a way that is adequate for patient nationally and within keeping of local traditions. I think that's also something to take away from this discussion.
Yeah, that's very important, and therefore GINA involves the national GINA ambassadors to implement the GINA guidelines locally or nationally and adapt according to the different healthcare systems. But I give the floor to Arzu to close this session.
And thanks very much to our panel for all your input you put today, and to the ERS, of course, supporting this great initiative. We are very much happy to be a part of this session tonight. And I would like to give the stage to Meher.
Thank you, Arzu. And of course, thanks to our online participants today for joining us and for your many questions. A recording of the discussion will be available to rewatch on the ERS Respiratory channel. And the ERS Vision Live series will continue. A new live discussion panel will feature on the ERS Respiratory channel each month, bringing together key individuals to discuss hot topic areas within respiratory medicine and science. We hope you can join us again in September.